So I guess we'll get started.
Again, I'm Ashley Crane. Nice to see everybody. We're going to review the BSCS Chapter 17, which is Vitreous Retinal Surgery. This is just, basically I'm just going to review what's in your book and show some videos, and we can discuss anything you guys want to discuss in terms of surgical retina. It's a very large topic to cover in a short time, so I think it's probably best that we just review what's going to be required from you from OCAPs and boards. So first we'll talk about the uses of pars plana vitrectomy, and please stop me if you have any questions. But there are 4 uses, general uses of pars plana vitrectomy. The first is to remove vitreous opacities, probably the least serious of the 4. Relieving vitreoretinal traction is very important. Restoring the normal anatomical relationship of the retina and RPE oftentimes comes with relieving vitreoretinal traction, and accessing the subretinal space, which is not a very common part of vitreoretinal surgery, but it can be useful. So first, I imagine most people have seen a pars plana vitrectomy, but could be that maybe some of the first years haven't seen one yet. Is that true? Or has everybody seen?
Yeah,
true. Okay.
True.
Yeah. My training as well would have been like that. So there are 3 ports used to do a pars plana vitrectomy. First, there is an infusion, and it usually goes inferior in the pars plana, about 3.5 to 4 millimeters posterior to the limbus. It is, hooked up to the machine, the vitrectomy machine, and it is supposed to maintain a constant intraocular pressure with its various sensors. There's also another port used for endoillumination, so that's the device called the light pipe, which goes through another trocar. And then there is the vitrectomy instrument, and that's the third. It goes through a third port, and several other instruments can be used instead of the vitrector, and you can even put in a 4th port with a light pipe, a lighting system that is not manually controlled, and use both hands with some of these instruments. And so then you're looking through the microscope with an indirect viewing system with an inversion mechanism, which might be in your hospital a biome or a resite. It's attached to the microscope. So there are 3 major gauges that are used for our trocars these days. There's still 20 gauge available, but it is not very frequently used, except for maybe in lensectomies, and maybe some surgeons prefer that, but it is not commonly used anymore. The 23 gauge, 25 gauge, and 27 gauge are the sizes of the modern instrumentation, and you can see up here that well, this one's kind of off the page, but starting at the 20 gauge, you have 0.9 millimeters, and it goes down to 0.4 millimeters on the 27 gauge. And then there are tampons used, which we'll discuss a little bit later. The most common used in the U.S. are these 4 tampons, 2 types of gas, C3F8 and SF6, and then oil, a silicone oil tamponade, 1,000 or 5,000 oil. So the first disease that is discussed in the BCSC for which vitrectomy is used is vitrectomy for macular disease, specifically for epiretinal membranes. So I always, in residency, in my clinic, would sometimes wonder when I should send these people, what I should be looking for in these people to refer out to retina. And these are patients, the patients that would benefit from this are not your little old lady of 2030, 2040 who's super happy and says that there's nothing wrong with them, but they have a terrible looking OCT. These are patients that need surgery for ERMs or would benefit from them, have a lot of metamorphopsia, and oftentimes have loss of central vision. I think 2040 is a good general benchmark to start thinking about it. But if they're 20/60 and have 0 complaints, then I would not do a surgery on them. And if they're 20/30 and the most miserable people because of the metamorphopsia, then that they could be considered. There are a couple things that you should discuss with them if, well, you don't have to discuss it, but if you were prepping them for surgery, you would. There is always a progression of nuclear sclerosis in pars plana vitrectomy in adults, and there is a small risk of retinal tear or detachment. I usually counsel people 2% to 5% is, probably 5% is the highest number that I see in the literature. So what happens during that surgery is that there's a pars plana vitrectomy in which all those instruments are inserted into the eye, and the vitreous is removed, and then there is a membrane peel performed with forceps. And then really these patients oftentimes gain about maybe half of what they lost, but you can say sometimes about 2 lines depending on how much they've lost. And it is a very slow improvement sometimes. For some patients, they may improve over years, up to 1 year, 2 years even.
Quick question. Is the
Yes.
5% a lifetime risk of
RD?
Or is it just like
I
30
think
days after the surgery?
for the most part, it's within the year after surgery, but certainly they can happen at any time. Vitrectomy for macular disease, the next topic is vitreomacular attraction. So this is when there's an incomplete PVD, and basically there's traction on the fovea, as you can see here on the OCT. And it can cause basically cystic spaces in the macula, or even subretinal elevation or elevation of the retina, so subretinal fluid or shallow retinal detachment focally. And patients oftentimes complain more about these symptoms than with ERM. So what is needed for this surgery is less than the membrane surgery. It's just the pars plana vitrectomy, and you have to make sure to lift the posterior hyaloid. And then, so it in general is a pretty straightforward surgery, because this is the first, almost always the first step of any vitreoretinal surgery, is just to go in and lift the hyaloid.
Is there any higher risk of retinal detachment or tear?
It should be the same as epiretinal membrane approximately, because the epiretinal membrane peeling, in my experience, I don't find any reason that actually just taking off the membrane from the macula increases your risk much. It's basically just doing a vitrectomy and lifting the hyaloid, although ERMs can already have their hyaloid lifted more often, well, obviously, than vitreomacular attraction. So then you're just shaving the peripheral vitreous, and that is going, you're pulling on something that is pulling on the vitreous base. And although our cutters are really good, and as the cutters advance, there's less traction placed, and so presumably improved risk, but it should be about the same for the two. So vitrectomy for macular disease number 3, idiopathic macular holes. So partial thickness holes are almost never, in my experience, operated on because they don't usually improve very much if you were to do it. But full thickness macular holes between stages 2 and 4, as you can see here and review on your own as well, the different stages, because those probably will be up for grabs on your OCAPs and your boards. But the surgery for them is perform a vitrectomy, removing of lifting the hyaloid if it's still down, the peripheral, removal of the peripheral vitreous, and you can also, depending on which stage of hole you have, you can peel off the internal limiting membrane with forceps. And oftentimes that's done with the help of a stain, which stains the internal limiting membrane. The stain that is most commonly used is either ICG stain or one of the blue stains that are sometimes they're not quite currently available, but they'll be available in April again. And then, so the IOM is usually peeled in stage 3 to 4 macular holes, not thought to be entirely necessary for stage 2 macular holes, but some people might do it anyway. And then there's a gas tamponade that is placed, so the fluid in the eye is removed and replaced with air, and then the air is replaced with a gas tamponade, and then face down positioning is instructed for various time points, either somewhere between a few hours and a few weeks. Is it's a very broad time point. Now, what does everyone here put? How long do you put them face down? 5 days or something?
5 days.
5 days.
Macular hole?
For macular hole.
3 days.
3 days.
I do until bedtime.
Okay. I do 7 days. It's just how I was trained to. So it's just, you know. There are some studies. One study that showed they basically got OCTs through gas bubbles on very soon after surgery, and almost everyone who was going to close had closed within 24 hours. So there's also vitrectomy for subretinal or for submacular hemorrhage. This is not necessarily that common, although I imagine there are some surgeons who really think this works really well and other surgeons who don't think it works really well. And I think on a population base, it's not super common. Individually, I've seen I did this on a couple of patients, and one patient was 20/25 afterwards. I think it was this guy actually, and that I'll show you a video of. But in general, it's not proven to be any better than anti-VEGF. So you could do an evacuation of the blood, which is very difficult, but pneumatic displacement with TPA is probably of the options, the more common option, I imagine. And sometimes there's positioning and tamponade. But I'll show you, I think this is the first one I did because I have not done very many of them because it's just not very common. So this is, you can see that this is done for very large hemorrhages, like arcade to arcade. Hopefully this will work. Well, that will be so sad if none of the videos work. Okay, here we go. So basically, a pars plana vitrectomy is performed. Usually the hyaloid would be lifted. You see this huge hemorrhage. I cannot believe that this guy did as well as he did. And when you look at these big submacular hemorrhages, you have to think about why they got the hemorrhage. Patients with AMD are not going to do that well. Their retina, their cord, it's all unhealthy. But if you had, for instance, retinal detachment that had a submacular hemorrhage and the patient was very young, those patients are going to do extremely well because the pathology was not in their macula. Go ahead.
When you talk about
Yeah, sorry. Sorry. Go ahead.
Are you just? So I feel like I haven't seen too much of
Yeah.
submacular hemorrhage.
So this is an example of a submacular hemorrhage. So this is a huge submacular hemorrhage. Oftentimes you might see patients with AMD with a small subretinal hemorrhage in the macula, right? And those patients are treated with anti-VEGF, and they continue. They might have lost vision from it, but these are. This surgery would probably only be done for somebody who had a massive bleed, who had good vision and then a massive bleed, and you're trying to, do anything to help.
Is that like a blood clot underneath?
Yes,
Okay.
that's
And then
just
what
the
you do.
big.
Do you make like a?
You're gonna see
anatomy
it.
into it?
Yeah, you'll see
And
it.
the location is subretinal?
Yes, the location of the blood is subretinal. Because if it were pre-retinal, you would just do a vitrectomy and you'd remove the vitreous, and this would not be nearly as big of a deal. But submacular hemorrhages are very serious. So let's see if I can get it started again. Okay, so I think in a minute I'm going to just prime the TPA. So the TPA is delivered on a little, on a very small cannula. Let's see if I can advance it. I'm hesitant to click this many times because, there we go. You can see that I'm just like priming that TPA there. And maybe that's primed quite enough.
Is that the same concentration you use for strokes?
You know, I don't remember the concentration that was used, but
The TPA's been a little bit of a challenge
Yeah,
because the
it's hard to get.
formulations changed.
right,
So the old papers, there's a new TPA,
yeah,
then there's an old TPA. And a lot of the literature is a TPA you can't get anymore.
right.
So presumably this is the newer one.
Right. This was only a few years ago, so you can see I'm extremely gingerly approaching the retina because this is probably a very stressful situation right now for me, and it wouldn't be so bad anymore. But that's the first time I'd ever done it. So then you'll basically make a retinotomy with this cannula, and then you'll start injecting the medication, and you'll try to make a bleb. Okay, retinotomy is there.
That's cool.
And then I was supervised at this point, and I'm sure my attending was like, "Stop bending the needle, needle straight." I can hear him in my head. And then you can see that there's lightening now around where the cannula is, and that's basically that the TPA is being injected, so that blood is being diluted. And then you would do it until the TPA goes beyond the hemorrhage. The bleb of subretinal fluid, including hemorrhage, is much bigger than it started. So, and then you would, so basically that's what you do, and then you position them, and you hope that the blood goes out of the macula. You're not taking it out. You're just breaking up the clot so it moves. And
Isn't it still considered like a nerve sensory detachment?
Yeah.
Don't you try to like remove all of it and put the macula flat? You just let the TPA work?
yes,
No, that doesn't work. We used to do
yes.
that. It's not.
Yes.
really hard
It's
to
very
control.
difficult
It's hard
to
to
get.
get.
To remove blood like that, you'd probably have to make a huge retinectomy, basically, and flap the retina over and like suck it out. Don't do it. Don't. That's
We've done that. There's
don't
all
do
sorts
it.
of ways.
It was tried. It's been tried.
It's not, that most of them don't work.
Yeah. So, and then there's the fluid air exchange, etc. Okay. So I'm just going to try to show some videos that are cool so you guys can see a little bit of what we do, but this is not a common surgery. So anyway, okay, let's keep going. So historically, there was surgery for subfoveal CNVMs. That was prior to my training. It was in vogue. The goals would be to relocate the phobia, over the healthy RPE. Also, pars plana vitrectomy and excision of the subfoveal CNV through a small retinotomy. But then it was shown to have no benefit, and for most people, for patients with AMD, and a modest benefit from those who had CNVs from POS or idiopathic if their vision was less than 2100. There's also option of pars plana vitrectomy and macular translocation. These, I don't think these will be on your boards at all because they're just not used. And in my experience, they don't ask, at least on the actual boards, things that are so not current. So let's talk about vitrectomy that was all for macular disease. Then you have for diabetic retinopathy. Non-clearing vitreous hemorrhage is probably another thing you guys might have in your clinics that you wonder, when do I send this to retina? And it's kind of up to you these days. If somebody has a bilateral vitreous hemorrhage, or they're monocular, or they have poor vision in the other eye, then you can send these earlier. I think that we used to wait oftentimes 3 months, and the patients would get injections, and I still do that if the patient is not eager, and sometimes I'll just let them go for a long time if they're really not eager for surgery, as long as they're getting injections. But I would say that with the better instrumentation, vitrectomy has become safer and safer, and then it has let people have the option of treating these patients earlier. And it's also really nice, I'm sure that diabetics sometimes are hard to get back into the clinic. It's hard to finish a PRP, and if they have a bad vitreous hemorrhage, their potential loss for follow-up just increases, and So sometimes it's better for these patients to just take them, remove the hemorrhage, lift the hyaloid, which can decrease your risk for tractional detachment, and put in a full PRP at that time, and then they don't have to be treated again, you know. Some people even would peel the ILM at that moment, which I usually wouldn't do that on that surgery, but a lot of people might, and then they're basically, if they've had cataract surgery, then like that's it, you know. Okay, so let me see if anything else. Okay, so obviously if you think that the patient has a vitreous hemorrhage and they have a tractional detachment that threatens or involves the macula, maybe they need to go earlier. You don't want to be observing them with the macula off detachment for months. Or if you think they have a RRD, then they should go quickly.
Yes, what's that mean, threatening the macula?
So tractional detachments are treated differently than rhegmatogenous detachments. And so if a rhegmatogenous detachment, if the macula is on, you're going to surgery very quickly to make sure that it doesn't detach. But oftentimes, tractional detachments in the periphery are observed because they progress so slowly that sometimes they never progress to cause vision loss. So if you have a detachment that splits the macula or is very close to the fovea, you might, and then they have a vitreous hemorrhage, you can't tell where that detachment is anymore. Even on ultrasound, you can't tell where the fovea is exactly, you know? So they might go earlier.
What about TRDs in the macula but not threatening the fovea?
That's up to the surgeon oftentimes. Oftentimes people will watch those and not, you know, because they oftentimes don't progress, they progress very slowly, and surgery, these patients are really sick, and surgery is an insult to their eye. And I've seen people with good vision who undergo surgery and for a reasonable reason who end up with vision that was poorer even though the surgery went perfectly well. So you have to think about that. Okay, so so tractional retinal detachments occur when the hyaloid shrinks, but it cannot come loose. A PVD cannot happen because there's neovascularization and basically an adhesion between the hyaloid and the neovascular membrane. So we talked about that it's indicated when the TRD threatens or involves the macula, or when other reasons require for you to go to surgery, like a non-clearing vitreous hemorrhage. Oftentimes patients, you should also, this is another thing from your guys' clinics now or whenever, when you're in practice, PRP is usually undertaken before the vitrectomy. It's easier when things are kind of tacked down because you're pulling against the retina, and it's easier to have that done. If you have a tractional detachment that's so enormous that it involves the whole retina, sometimes it's not helpful to do that. And also, when you're doing the PRP, make sure to not get extremely close. Stay a couple disc diameters away, and you don't need to do the whole PRP in one day. I would say be more cautious with the amount of spots you're putting in than you would with somebody else, because it can cause crunching. It can. So preoperative anti-VEGF, some people use, some people don't. I always use anti-VEGF before a surgery. I usually do it just 2 days in advance because these patients are, by definition, the patients who have already detached, and they will crunch more oftentimes, but it helps minimize bleeding. Some people don't like it, they don't want any progression, or you might choose based on the patient. And you can also remember that the retina is oftentimes atrophic. Oftentimes the tractional component is thicker than the retina, and so when these membranes are contracting, they can pull little holes, little atrophic holes in the retina, and then you have a rhegmatogenous detachment at the same time. So you would want to take those quicker, and they'll progress quicker. And sometimes you can't tell, you know, sometimes you can't see these things. There's blood everywhere and you can't tell. Okay, so the surgery, and I'll show you a quick video of a small detachment in a minute, but surgery involves basically removing the cortical vitreous, separating the posterior hyaloid from the retina, and then trimming down or removing the adhesion. We call them pegs. Removing the adhesions with a variety of instruments, using endodiathermy to prevent or stop bleeding. And oftentimes, but not always, you can use a tamponade like gas or oil. And you don't have to necessarily do that unless there's a hole in the retina. You could have a tractional detachment that you basically relieve all the traction and leave them with no tamponade. And so that's different than most regmatagenous detachments that you're doing vitrectomies for. So here is, not all of these are my videos, but here is a video, and it was left-handed, so I don't think that's mine. So this is a tractional detachment that's pretty small, but has a significant, the macula is definitely detached. And you can see that there's a very much of an art to this type of surgery. You're trying to see where the attachments are, how you can lift the fibrovascular membranes off. A big part of it is separating, the most important part is separating the hyaloid, hyaloid from the retina, and that's actually very difficult. And I think vitreoretinal surgery, when you watch some videos or see it yourself, you'll really understand what the posterior hyaloid, what it is, and what it's hard to understand until you see these, you actually see it being removed, then you get kind of how it's inserted. So basically, the surgeon is going 360 around the detachment and trying to get a plane in between the posterior hyaloid and the retina. And then you basically picking off this membrane from the surface. Let me see if I can, maybe I'll advance it a little bit and see what kind of progress is made. But these surgeries can take a really long time. These can take 2 hours, could take more. Some people would do them much quicker, but it really depends on the surgeon and on the pathology. Let's see if we've made any progress so we've apparently made progress by then. Well, so I believe here that we're trying to decrease the bleeding. We've already gotten it seems like we already got the traction off. But basically you pick at it and try to separate the two. That's what it is. So here's scleral depression at the end of the surgery, shaving the vitreous base, then removing some of the blood, and a tamponade is happening now. Basically this is an important part of surgery. Fluid, if you want to get air or gas or oil in the eye, you have to take the fluid out because you can't just push the gas in. So you have an instrument called a soft tip, or an extrusion cannula that basically sucks the fluid out and air comes in the infusion line. So now you have an eye full of air, and then you kind of suck the fluid out from under the retina, and then you exchange that. So that was a fluid air exchange, and then you have an air, it's not really what we call it, but an air gas exchange to replace it. I imagine they use gas in this case. Okay, let's keep going to the next surgery. So they talk next about surgery for the complications of anterior segment surgery. And here's postoperative endophthalmitis. I'm sure probably everyone has seen this. But the most key parts are pain, vision loss, injection, fibrin, in my opinion. Some plus minuses are hypopyon, eyelid and corneal edema, vitreous haze and membranes. You might not see the vitreous haze and membranes, but the vitreous is involved by definition. It's typically during the first days or weeks after intraocular surgery or a procedure like an intravitreal injection. The acute onset endophthalmitis is within 6 weeks. Most typically coag negative staph, strep, and gram negatives. Chronic or delayed endophthalmitis after 6 weeks can be P. acnes is the famous one you'll see on the boards. Fungi can be as well, and coag negative staph is also listed in your book. Bleb associated endophthalmitis, which is probably the worst, that and traumatic are the kind of nastiest endophthalmitis, is oftentimes strep. Haemophilus and gram-positives. So there are lots of ways to do a tap and inject, and the BCSC goes through some details, but I usually use between a 27 and a 23 gauge needle depending on the patient. I like to use a short needle so that I don't have to worry about, in worrying about all the things that you're doing, I don't have to worry about how deep it is into the eye. So if possible. Sometimes when our first years were learning how to do these taps and injects, I would have them always use a butterfly. Although you can really collapse the tubing on the butterfly, but it's nice that they only had to do one thing at a time. So one person would be pulling, one person would just be holding. So you guys can think about that when you're learning how to do tap and injects. So there is a wide variety of what kind of syringe to use. In a person who's elderly or previously vitrectomized, I use the TB needle on the TB syringe, and it works. It's very easy. But on a 30-year-old patient with a traumatic endophthalmitis, this can be nearly impossible to get the fluid out. And so you might have to use a huge syringe, and I've seen 30 cc syringes being used for this, which can be really dangerous the moment you actually get the sample, because you can really reason the eye and cause a major problem. So be careful with young people and with large syringes. I prefer using a bigger needle and a smaller syringe. That seems safer to me than creating all this negative pressure. Vitreous sample should be between 0.2 and 0.5. That's easier said than done to get that exact number. But try not to get a whole cc. It will make, it'll be a difficult rest of your procedure. And the BCSC says to do an AC tap as well. I don't do this if I get a vitreous tap. Does everyone here get an AC taps?
I've never seen a vitreous tap. I've always seen AC tap with vitreous injection.
Okay.
How, I guess,
in my experience, typically for endophthalmitis, my protocol is always to get a vitreous tap. The yield of AC taps is lower, but there may be reasons why your professors prefer an AC tap and no vitreous tap. If you know what the organism is, if this is an endogenous endophthalmitis and the patient is hospitalized for X fungal, candidemia, then you don't even have to do that at all. You can just treat it. But I always do a vitreous tap.
I probably get a vitreous tap less than half the time, probably a third of the time I get it.
Yeah.
I've moved to doing it with the patient sitting up, because when you look at ultrasounds, the vitreous kind of falls, and then I kind of aim a little high, and I use a 26 gauge, and I leave a little tiny bit of air in the syringe, and I'll try to pull, and if I can't get it, then I push the little air to clear the syringe, move a little, and try to pull, and then if I can't get it, then I do an AC tap.
One good thing, if you're doing this on a pseudophakic patient, I find it's much easier. Obviously, you're not trying to avoid the lens, and you can retro illuminate. You can just have a pen light and shine it right into the through the pupil, and you can see your needle. And if you can get it right up behind the IOL, there's a space there that is, I think, much easier to get the vitreous, and it's also pretty safe because you know exactly where you are. So I used to do that. All right, so here is a tap and inject prep, standard type of prep. So you do a standard prep like you're doing an intravitreal injection. You can do subconj, I suppose topical, maybe if they're very elderly might be enough, but I usually do a retrobulbar or peribulbar block. That's totally up to the surgeon, and use a speculum. Then here are the options. This was what our residents would use, this setup of the needle and syringe, but there's so many different options. So pars plana entry of the needle, you can see that's the butterfly, and then you see that there are two people on this one and one person's taking it out. I think once you've done quite a few of these, it's not any easier to do it with two people. It's much easier to do it with one person, but when you're learning, sometimes it's really helpful. So the endophthalmitis vitrectomy study in 1995 compared, basically, it was looking at pars plana vitrectomy plus intravitreal antibiotics in the management of postoperative bacterial endophthalmitis. And it's within 6 weeks after the surgery that these patients had the endophthalmitis. This very well could be on your exam, and it's important. It's important. It actually it helps guide us currently. So they were randomized into either the pars plana vitrectomy plus injection or the vitreous tap and injection, and intravenous antibiotics. And the outcome measures were the vision and the media clarity. So intravenous antibiotics did not show a big, a statistically significant difference. There was also, in patients with light perception or, in hand motion or better vision, so better than light perception, there was no difference between the two groups either. So in patients with light perception vision, there were better results in the immediate pars plana vitrectomy group. Now, remember that if you'd have to read this study to know all the exclusion criteria, because there were a lot. And so if you have somebody with a terrible corneal wound, if you have someone with a melted cornea, if you have someone on tons of anticoagulation, you don't have to feel beholden to doing this. You have to use common sense. Some patients, if you can't see through the cornea to perform the surgery, those patients were excluded. So I always felt like when I was in residency, I had to push this patient is light perception. They just had cataract surgery. They must go, and that's not true. You can't always do it, even if you want to. So the injection options. You can see the EVS treatment here, and then the current recommendations. They were using amikacin. I have always used ceftazidime. And so basically you can use intravitreal steroids, which I always use in acute postoperative endophthalmitis, but I wouldn't if I think anything about the endophthalmitis is weird. The time period, anything is a little off, I don't use dexamethasone. Some people use subconjunctival antibiotics. I don't use that anymore. You're putting so much into the vitreous. I'm not sure that it's entirely necessary. Systemic antibiotics were used in the study but are not used that often anymore unless it's a systemic infection. And then systemic steroids, I have not gotten into the habit of ever using these, but you could. So chronic endophthalmitis, this is definitely a BCSC question. You see this peripheral white plaque and in the bag, and it causes granulomatous inflammation. So it's very fastidious and hard to treat. So oftentimes it is not fixed with, I think it just has this biofilm, and it is not fixed with just an intravitreal injection, even though you'd think that it would be. So oftentimes you have to do a vitrectomy, remove part of the capsule, and then inject, and then if that doesn't, if it recurs, then sometimes you have to explant the lens. So this will be a part of your training and learning, because everybody who does cataract surgery is going to have complications, and oftentimes retained lens material is one of those. So maybe in the literature it says that there's up to 1.1% incidence of this, and it will be more probably in training. And then basically the retained lens material, the nucleus itself, causes severe inflammation and high pressures. So cortical fragments might cause the same, but they oftentimes can resorb. But a big nuclear chunk will not resorb, and you basically have to remove it. So, and remember that during these surgeries, if you're phacoing vitreous, that's pulling on the vitreous, which is attached to the retina at the vitreous base, and there's a higher risk of detachment. We said that large pieces over 2 millimeters should be removed surgically. And then there's an instrument called the fragmentome, which is right now in many places is a larger 20 gauge instrument, though the 23s exist. And basically it's placed through a sclerotomy, and it's almost the same as a phaco. It's an ultrasound. It's almost the same. And so it basically can eat up the lens for the most part.
How soon after
Good question. I think if you know that there's retained lens material, there's really, and especially nucleus, there's no reason to wait to refer to your vitreoretinal colleagues. They can decide if the view is sufficient to proceed, but sooner is always better, and it should usually be within 14 days. But if this has been in the eye for 14 days and they've been on no steroids and the cornea is terrible, sometimes you can't see and you have to do what the situation allows.
You made two good points that I think are worth reiterating. One is that it's important when you're in cataract surgery not to dive down and try to
Right.
save yourself, so let it go.
Let it go.
Concentrate on getting the vitreous out of the anterior segment and put the lens implant in.
Yes.
Some people just panic and they just
And they
close
just,
up and.
yeah. I think that what you have to do is you get a good anterior vitrectomy. You try to clean the cortex, and then you try to put a lens either in the sulcus or an ACIOL or whatever you think, and then close the corneal wounds. You're gonna, people don't remember that when we're inserting our trocars, these, you're putting a lot of pressure on the globe, and those wounds will just open right back up. So close all your corneal wounds, just to kind of help the next person down the road, and refer quickly. Don't think like, oh, well, maybe that 4mm nuclear fragment, maybe it'll resolve and I won't have to send this out. It's just better for everybody to get them sooner.
And if the view is too poor for retinal surgery, can the cornea be scraped to improve the view, or
It can. I mean, usually we'll treat them with steroids for a short period, and oftentimes that helps because oftentimes the corneal edema was just from surgery. It was a long and complex surgery sometimes. So, and then you can use a variety of medication. I used to use glycerin. It's not usually available in a lot of places, but that can help you quickly. You can scrape the corneal epithelium if there's epithelial edema. That doesn't necessarily always help the stromal edema, but if you can get one of those out of the way, oftentimes, really the surgery for us, the only thing we have to do is get the nuclear piece out. We don't necessarily have to make it the prettiest surgery with a nice peripheral shave. It's kind of get the nuclear piece out,
I have a question. What's the benefit of inserting the IOL?
Well, the next person would have to do it, right? I think oftentimes the anterior segment surgeons are more used to putting in IOLs. The capsular bag may be easier to see. Say you've stained it, or you know where it is, you know where your rent was. We're not going to know where your rent was, if there's an anterior rent. And actually, a practical thing, a lot of places I do surgery don't have IOLs. So I must if I have your retained lens material today, and I think we should take it tomorrow because I could see today and God knows what's going to happen in 3 days. So I got to take it tomorrow, and then, we don't have a lens. You have to go back and do another surgery. Go ahead.
Would you ever be okay with a cataract surgeon doing a pars plana vitrectomy for vitreous Immitis?
If that surgeon had vitreoretinal training and happened to be doing cataract surgery for whatever reason, then okay. But I would not, in general, like that to happen. Where I trained, several of the surgeons would do an anterior vitrectomy with pars plana trocars, and I always was very worried. I would always be lingering outside their door when I heard that was going to happen. So, and that was mostly for like IOLs cases that they wanted to get a good anterior vitrectomy with, and they wanted to use a scleral tunnel. That's one. So anyway, but I don't think it's not a common thing for an anterior segment surgeon to go through the pars plana. I don't think it's a good idea. Let's see. We've talked about all of these actually. Yeah. And only try to get the fragment if it's in a place where you usually operate. If it's in a place where you don't usually operate, don't operate on it on that situation. Posteriorly dislocated IOLs. Oftentimes they require pars plana vitrectomy and removal of the adhesions to the IOL. This is not a surgical emergency, so don't get too worked up in your own clinic if you see this. You can refer, unless there's a detachment associated or a tear, but you can refer it with time to the surgeon, and they can order the lens and do this in a. Options include repositioning into the sulcus. I've seen that happen if you have a 3-piece in the bag it falls through and you can get it into the AC and put it in the sulcus. That's possible, although the capsule, oftentimes the anterior capsule phimoses, and so when you try to bring it through, it messes up the anterior capsule and you can't get it in. An AC IOL or a sutured or scleral fixated IOL, those are options. So they talk about, this is kind of interesting, they talk about CME after anterior segment surgery, and I guess in this chapter it's unusual, but they do talk about how it oftentimes resolves spontaneously. Use a steroid or NSAID. You can use periocular or intravitreal steroids. Once in a while, anti-VEGF helps. Say they're diabetic, and so there is multifactorial. Sometimes there is a vitreous adhesion from the vitreous to the cornea, and lysing that may relieve the traction and relieve CME. And sometimes it requires IOL repositioning, exchange, or removal if the IOL is the problem. Suprachoroidal hemorrhage is a rare but really terrible complication after intraocular surgery. We have risk factors at the bottom. Those risk factors are always on these exams. So age, glaucoma, myopia, aphakia, cardiovascular disease, hypertension. Sturge-Weber was new to me. I didn't remember that before. And intra-op tachycardia. So basically, transient hypotony can cause rupture of the posterior ciliary arteries, and blood in the suprachoroidal and superciliary space accumulates. Everybody know what the superciliary space is? Can anyone tell me? It says it's above the ciliary body instead of above the choroid. So just anatomically, that's where it is. But it's not a word that's used that often in your books.
So is that contiguous?
Yes.
So it's just
with the suprachoroidal
posterior
space.
to anterior?
It's anterior, yes. Appositional or kissing choroidals are when the retinal surfaces touch one another, and that is considered of an urgent situation. These can be expulsive or non-expulsive. So basically, expulsive meaning the intraocular contents are outside the eye. Suprachoroidal hemorrhage management. If this happens during a surgery, a glaucoma surgery, a cataract surgery, just stop and close everything. And if it happens afterwards and everything is closed, then it's observation, supportive care for a couple of weeks, and then you can a vitreoretinal, or sometimes actually the glaucoma people, if they had this, they would drain them themselves. But they would allow for liquefaction. They just won't drain. If you took them the next day, they just don't drain. They're clotted. Perhaps if you did it in the same moment, it would drain, but it would probably just keep bleeding. So probably not a good idea. So indications for draining may be on your test. Pain, pressure increases, detachments, the kissing choroidals with ciliary body rotation and angle closure. Probably, yeah, I think all of those are reasonable. So the technique includes an AC maintainer. Basically, you don't want to drop your pressure again once you've let all this fluid out, right? So something needs to keep your pressure at a normal level, or even a little high maybe. So you use an AC maintainer or an infusion. I would just use my vitrectomy machine with its regular infusion, and you make full thickness sclerotomies. Some people would do a vitrectomy at the same time, but really you're just trying to drain the choroidals. Needle penetration of the globe. Dr. Finlay gave a nice review of this when we talked about the one that she treated. But these blocks do go close to the globe, so there is a potential for entering the globe. The risk factors include high axial myopia, posterior staphyloma, a previous buccal, poor cooperation, etc. And so then we'll talk about retinal detachment surgery. We have about 10 minutes left. And so retinal detachments are rhegmatogenous or tractional. Our RDs have an incidence of 1 in 15,000 patients. The risk is less than 1%, maybe less than 1 or 2%. It's higher with young age male patients, longer axial length. And this is important for you guys. Please remember that if there's a posterior capsular rupture, we've interrupted the vitreous. and it increases the risk by up to 20 times. So you should watch those patients more carefully. Maybe you want to do a dilated fundus exam more often or more thoroughly than your average person. Maybe you want to dilate them not at your standard post-op month 1 or whenever you do it. The BCSC states that YAG does not appreciably increase the risk of retinal detachment. There are varied literature, there's varied opinions in the literature for that. I've seen very different things and facts than that, but for your purposes, it says that it doesn't.
Is there a time frame associated with increased risk?
It's usually within the first year, but closer to the surgery is more, it usually happens within a month, 2 months. What does everyone think?
I think it's bimodal. You can have people who at the time of surgery had active vitreous traction and they're getting a tear at the time of surgery, they're going to detach sooner. Other people are going to develop a PVD earlier than they would otherwise.
Right.
And that might occur 1, 2, 3, 5 years later, but earlier than they would otherwise.
Right.
So there'll be a second bump that
Exactly,
get a
that's
detachment.
true. And young people who are very young and have cataract surgery for whatever reason tend to do worse. I see more detachments from the person who had cataract surgery at age 40 for whatever reason you don't know. So there are several surgical options for RRD. The non-surgical option is observation. You can do that for asymptomatic, localized detachments or big detachments in someone who's 100 years old with dementia and you can't operate on them, or then that's an option. Laser demarcation is an option for small detachments. So if you have a question, please ask someone before you laser demarcate a detachment. I have seen some residents laser demarcate enormous detachments, and then it makes the surgeon's life way more difficult. So if there's any question like, oh, is this too big? Or if you start and you say, oh, I'm not taking up in this small area I thought the detachment was. Maybe there's fluid around it. Don't just keep going farther and farther. Just stop and ask the question. And pneumatic retinopexy, and not you residents. I've seen do that. My own residents. Pneumatic retinopexy is an option for retinal detachments, as well as scleral buckling, vitrectomy plus or minus scleral buckle. So we'll talk about a couple of those. So the requirements of pneumatic retinopexy probably is something that could be testable. So does anyone remember them? I mean, I wonder if I can go backwards. Does anyone know the requirements for doing a pneumatic, or just a few of them?
Superior.
Okay, superior.
Right.
How long? How many clock hours?
Let's say 2.
8? Good. Okay, next.
Confidence that all the breaks were found.
Right. And that kind of goes with media opacity. So there's a lot of blood. You can't see the retina in all the quadrants. Maybe not the best person. Anybody else?
Good patient cooperation?
Yes, they have to position well. Anybody else?
Small tear.
Yeah, it's a single break. It doesn't necessarily have to be a small tear, but the tears have to be close to each other, and it is easier if it's not huge. This wouldn't work well for a GRT, a giant retinal tear. And then the absence of high-grade PVR. So the gas bubble basically pushes the break back, reopposes the break back to the retina where it started, and cryo or laser is used to seal the break. The BCSC says that there's a 73% success rate, and also says that, quotes this 1989 paper that says that it yields better visual outcomes versus buckles and macula off detachments. Our vitrectomy instrumentation gets better and better, and so sometimes these pieces of information might be a little outdated because they're only comparing this to scleral buckles at that time. And success rate is variable depending on what you look at. Scleral buckling, basically the goal is to support your retinal breaks. You want to push on the breaks with a band or a sponge that imbricates the retina and the sclera. and then you would use cryo or even laser if you can make it happen to close the breaks as well. Sometimes you'll use external drainage to try to get the retina to lay on the buckle, and sometimes you'll use an AC tap to decrease the pressure, because when you pull up a buckle, the pressure will go way up. And you may use a gas tamponade at the end of the surgery just to make them reoppose each other. And there are several complications that are listed down here. I'm not sure how, I've never seen anybody ask questions about that on the boards, but here is a video of a couple techniques for scleral buckle. Let's see if this works. So this, to me, looks like a young person. I can't remember this person exactly, but it looks like a young person maybe after trauma or something like that. You can see the tenons is really thick. That's why it looks like a young person. So basically, you're doing a 360-degree conjunctival peritomy. This is for an encircling buckle. There are other types of buckles. You're isolating the muscles. You're basically making loops around them so that you can pull the eye in different ways. This is the person who looks like trauma. You can see that they're missing some of their iris. And then there are a couple ways to put the buckle around. The first part of the video will show what I usually use, which is making scleral tunnels, and basically using a blade to make a little tunnel, and then well, you'll see. So 2 little parallel partial thickness sclerotomies, and then an instrument that connects them. And then you pass the buckle. If anybody's not seen a buckle, you pass the buckle, if it's an encircling buckle, through those loops and under the muscles, and there's another kind of a silicone sleeve that connects the 2 ends, and then you pull it up. And then there's basically the same way to do this is with sutures. So you can make a little mattress suture, and the suturing is really necessary. You really can't do the tunnels if you're using different types of elements, like not an encircling buckle. You have to do it with sutures, which is a very good way to do it too. So basically, you can see that a loop was made when we pull this. There's like a little loop, and then instead of the well, you'll see it here. You're just putting the buckle through this little loop instead of through the scleral loop. It's basically the same thing. Okay. So pars plana vitrectomy, the goals are to remove the cortical vitreous and to drain the fluid. Basically, you also want to give a tamponade to push the retina back in place and to close the break, and create a chorioretinal adhesion with a laser or a cryo. And this is usually a 3-port vitrectomy. You can use it with a scleral buckle. The steps are important. Can a third year tell me the steps of a typical detachment, just a straightforward detachment repair, or anybody?
Using a pars plana vitrectomy?
Just say you're just doing a pars plana vitrectomy. What's the first thing you do?
You want to do core vitrectomy?
Exactly. So you're and make sure the hyaloid is lifted. Okay.
And then after that, you want to shave the vitreous kind of around.
Yep.
Breaks, and especially more peripheral.
Uh-huh.
And
Exactly.
then after that, you want to make sure that you visualize all the different breaks.
Yes. Great.
You want to make sure, and at that point, as long as all the vitreous traction has been relieved, you could either do endo laser, or you could put, if it's a really bad one, you could put oil primarily, or you could do a gas tamponade.
Okay. So what's the step in between your peripheral vitrectomy and your laser? Do you guys know what that step might be? This is a step that I was just saying earlier, how that it's hard to understand it until you are more into it. But you have to, yeah, well, the hyaloid's lifted because we did the core and we did the peripheral. What were you going to say?
Like look at air and look
Yes,
at the
exactly. You have to flatten the retina. You can't laser over detached retina. So that's an important part, and something that when you're learning is a step that gets missed. I would remember the residents that just missed, if I would have them dictate, the residents would just miss that part, and I would say like, well, they don't know exactly what's happening in that step. So basically, you have to complete a PVD, you shave the vitreous, then you drain the subretinal fluid. There are several ways to drain that. Retinotomy is a hole in the retina that you make. Perfluoron is a heavy liquid that you place on the retina, and basically it squeegees the fluid out of the break or out to the periphery. Or external drainage is an option, even in a vitrectomy. You can go through the sclera and drain the fluid. Not as common. There are some devices that are used for that, though. In PVR, sometimes you do a membrane peel or a retinectomy, and then after you've drained the subretinal fluid, that's basically a fluid-air exchange, so you're under air now, and your retina's flat, you can laser, and then you tamponade. So, great.
What I
Here,
also do is I'll take the intraocular cautery and
Mhm.
just kind of
mark,
cauterize around
yes.
the edges of
You
the breaks.
you mark the break.
'Cause when it flattens, sometimes it's
you
hard
can't
to
see
see where
it.
the tear is,
Right.
so you know where to laser.
That's, yes, and that's a step for, and it doesn't bleed.
Right.
That's a step for the surgeon's ease. You could theoretically do that, do the whole surgery and not mark the break. It would still work, but it would be very difficult to see it. Okay, so here is a video of lifting the hyaloid. I think that this shows you really what the hyaloid looks like. So it's stained with Kenalog here, or triamcinolone, and basically it's being just lifted off. And you can really understand the anatomy when you see it coming off. So there's off superiorly, and then you're going to take it nasally, or you kind of work your way around. So okay, then you're going to cut some of it, and you might keep lifting.
This is after you've done your core vitrectomy?
This is, yes, effectively yes. Patient is not detached, but it's having surgery for something else. Or maybe they are detached in the periphery that I can't see right now. Okay, so let's go on to see if we're almost done here. So I just want to show some videos because we'll just show you steps of surgery. So this is a total detachment with proliferative vitreoretinopathy. As you can see inferiorly, which is at the superior part of your screen, there's a large area of kind of traction. The retina is very contracted looking up there. So this video will just show some advanced techniques that so you know what they're talking about when someone says a retinectomy. Basically, this is a redetachment. There's already a buckle on here, and so this is PFO that's being placed on the retina to basically flatten the retina so that you can work. So, and you can see that all the fluid is being pushed out towards the sides, and if there's an open break, it'll come out into the vitreous from the sides. Okay, then there's a little capsular opacity, so cleaning out the capsule. And those little bubbles floating around are PFO bubbles. So I can't remember if we peel something there or not, but basically now really just looking for, okay. So we're looking for PVR membranes. We're peeling some of those membranes off the surface of the macula. It's much harder to do under that PFO than not under the PFO, but you're forced to do it because it was so bullous. And then you're gonna we're looking when you put the PFO down, you can see if it's gonna flatten, which it probably is not, because why would it have detached unless there was a break? And so then basically maybe you're picking at some membranes, and then here's the retinectomy is going to start. So this is marking of the retinectomy with endodiathermy. So you have to cauterize the edge of where you're going to cut. So making at least these retinectomies are usually at least 3 clock hours, and you're trying to make it really peripheral so you're not losing a lot of space. If it doesn't work and you need another retinectomy, you don't want to be like on top of the macula. So you're doing as peripheral as possible. I'm just going to cut out basically the retina. And basically then the retina was taut, and then it's just gonna lay down and you're gonna laser it flat there. So this is what a retinectomy is. So these are several of the steps that maybe you've heard of but never seen and don't quite understand when you see it in the notes, right? So membrane peel and retinectomy. Okay, so that's basically releasing the retina, and then we're going to probably fill up more with PFO, and then we're going to go to air. So the visualization is sometimes very difficult, but we will basically are going to drain all the fluid out so it's nice and flat, and then it's going to be lasered. So this is after, you can laser it under the PFO or after the PFO is taken out. So there's laser, and then oils going in. And then you're probably going to, and that's just, this is the end where we're taking all the air out. And we're suturing our sclerotomies because you don't want oil subconj, it's not a good look. Okay, and I think that we just have one more slide. Complications of, or maybe a couple. Complications of pars plana vitrectomy is nuclear sclerosis, glaucoma, PVR, detachment, endophthalmitis. Postoperative, there should be a P there, break or RD. And these, I'm not sure that those are very common. When you have silicone oil, you can have glaucoma or band keratopathy. And then complex are retinal detachments we won't go into because your book didn't, but recurrent detachments, giant retinal tears. Vitreous hemorrhage, I don't know what they were getting at there, but PVR for sure. And the last slide is that the silicone study might be something you should review before your test. And basically it was looking at patients with PVR, grade C, 3 PVR or above, and showed, and looked at the difference between how they did with silicone oil versus C3F8 in their outcome of vision 5/200 or better, which is still poor vision, and macular reattachment for 6 months after surgery, and there was no statistically significant difference between the two. So that might be on your tests, but that doesn't apply to most of your detachments. Okay, anybody have any other questions? Sorry, that's a lot of stuff to go through in a short period. You could spend weeks. No questions about detachments or? Okay. All right. Thank you.
Nice summary.
You're ready.